Good morning, everyone. Thank you for joining us. This is Gary Greenswag, and happy to welcome you to our clinical update grand rounds for this morning. I do want to say that this is breakout session number 2 from our virtual Physician and APP Clinical Symposium. We had the plenary session live in person with virtual attendance a few weeks ago in Chicago. We had one of the breakout sessions in hospital medicine last week, and this week in advances in oncology. And we are very pleased to have as our guests Dr. Peter Emanuel, Jill Tapper, and Dr. Samer Shihabi. And so I'm going to just take a moment to introduce those folks, and then we'll turn it over to the team. So again, welcome. Thanks for joining us. First, Dr. Emanuel graduated from the University of Wisconsin School of Medicine, completed his training at the University of Alabama at Birmingham, and was on their faculty for 16 years, attaining a rank of professor of medicine and serving as the interim director of University of Alabama's Comprehensive Cancer Center. He then moved to the University of Arkansas, where he served as the Cancer Institute director for 11 years. In 2018, he joined CHI St. Vincent in Little Rock, Arkansas, as the director of oncology services. And in May of this year, he became the system physician vice president for the Oncology Clinical Institute for Common Spirit Health. And we've been very happy to have him on our team to guide us in these endeavors. So welcome, Peter. Jill Tapper joined our team as the system director for Precision Medicine in June of this year. And she has a 20-year history and experience of leading the development and implementation of genetic and genomic-based precision medicine services and programs in the academic medical center, in community health systems, and in commercial settings. She was part of a team, we were talking about this before the call, at the Medical College of Wisconsin, who built one of the first genomic medicine programs based on this, on the whole human genome sequencing to guide the care of pediatric and adult patients. And they both did the sequencing and then figured out what to do with it in their clinic. And Dr. Shihabi is a medical oncologist and hematologist at the Dignity Health Cancer Institute in Sacramento, California. He's a member of the Mercy Medical Group. He's been in Sacramento for 20 years and with the group for 7 years. He completed his fellowship training at the University of Pittsburgh. So with that, Peter, I'm going to turn it over to you, and I think you're going to share your screen. And thank you for being with us, all of you, this morning.
Good morning, everyone. So these are my disclosures, and while I leave the disclosure slide up, let me preface the talk today that scientists have always argued for decades and decades, basically as long as scientists have been around, that if we know the pathogenesis of a disease, then we can most rationally create therapies to target that pathogenesis. And over the last few decades, that stance has been proven true in the setting of precision medicine and oncology. So today, I first want to take you back in time several decades to show you where precision oncology had its roots, had its initial successes, and then I'm going to rapidly bring you up to present day to show you where precision oncology stands, at least this week, knowing that the landscape in precision oncology is changing on an almost weekly basis. My clinical background is in hematological malignancies, and even though I am the physician lead for the Oncology Clinical Institute in Common Spirit Health, that's a 50% effort, and I continue to see patients 50% of the time, and most of those patients are heme malignancy patients. And this will be obvious by my talk, but that's also exactly where precision oncology started. So CML, which we'll start with, is the poster child for targeted therapy and the start of precision medicine and oncology. CML was the first disease to show the first direct link between chromosomal abnormalities to any sort of human malignancy. And this started back in 1960 when Knoll and Hungerford, two scientists working in Philadelphia in 1960, described a short chromosome 22. They actually didn't describe the 922. I'll get to that in a second. But they described a short chromosome 22 and dubbed it the Philadelphia chromosome, because that's where they were at the time. It was actually not until 1973 that Janet Rowley in Chicago described the actual translocation between chromosomes 9 and 22. It then took until 1985 to describe that this translocation involved a gene called breakpoint cluster region, or BCR gene, on chromosome 9, and fused that as a result of this translocation to the Abel proto-oncogene on chromosome 22. It then took until 1998 to find a drug, imatinib, that hit this translocation fusion gene, and the FDA then approved it in May of 2001. So now I'm going to show you an old video clip from 1999. It's fuzzy because our technologies for embedding these kinds of things into presentations have evolved vastly over the last 23 years. But this is a news clip from 1999, and it highlights a woman who was the 7th patient ever in the world to receive an imatinib during its initial phase 1 trial. And at the time, as is shown in the video clip, it was referred to by STI 571, which was its predecessor name before it was given the generic name of imatinib, and STI stands for signal transduction inhibitor.
The special Lifeline report tonight, Best Medicine, major development in cancer research announced at a conference in San Francisco. Scientists reporting positive results in human trials of a simple pill that can zero in on cancer cells, stopping even some of the most deadly malignancies. NBC's chief science correspondent is Robert Bazell.
Yeah, that's right. For Judy Oram and her husband Frank, it was to be the last family vacation, a trip to New Zealand with their 2 children.
I looked at it as a family memory trip and said, they're going to have something to remember that we all did together when I'm gone.
A final trip because 5 years ago, her doctor gave her devastating news: leukemia, cancer of the blood.
I hear the word cancer first, and then it's yeah, it just drops the whole bottom out of you. She told me I had 3 to 5 years.
Just like that, 3 to 5 years. Judy tried standard treatments. They didn't work, made her sick, and the leukemia got worse. Until 15 months ago, she started the experimental pill called STI 571. The results? Sensational, without the terrible side effects of traditional cancer treatment. No shots, no infusions, no fatigue, hair loss, or nausea.
It affected everything. The thing about this drug is it basically goes right to the cause. It leaves the other cells alone. So I have my energy.
Developed by Novartis Pharmaceutical, the pill kills leukemia cells by targeting and knocking out a key enzyme they need to grow. Judy was the 7th patient to get it. Now she meets regularly as part of a support group with some of the 1,000 others on the drug, most of them getting the same remarkable results.
I certainly dreamed that this could happen, and I'm just incredibly grateful to be a part of these types of advances.
Judy, what would your life be like right now if you hadn't gotten this experimental pill?
I think I'd be dead. I really do.
After what was to be the final trip to New Zealand, Judy Oram shared a sad thought with her husband. She wanted her ashes scattered high up on Mount Hood near her home.
Now when it comes summer, I can walk up to the place where I told them to scatter the ashes.
A life saved in what many see as the beginning of a whole new era in fighting cancer. Robert Bazell, NBC News, Portland, Oregon.
And as far as I know, every summer she still goes up on Mount Hood and visits where the place where her ashes were supposed to be scattered. So these are the players that you saw in the video, and this is them 23 years later. This is Judy Oram. Brian Drucker, who many think still may get the Nobel Prize one of these days, is still at Oregon as the Cancer Center Director at Oregon. Robert Bazell, the journalist, has actually left journalism. And I think he works as a consultant for various universities. Tom Brokaw has actually had his own run-in with cancer, but I think is doing well. If we go back to the pathogenesis of this disease and where this drug emanated. So this is a random cell showing the fusion gene in the cytoplasm beyond the cell membrane and influencing many things. And this is the BCR part of chromosome 9 fused to the ABL proto-oncogene on chromosome 22. And this fusion gene messes up all the signaling in the cells. So in the normal situation, if a growing, developing white blood cell, if the body needs more of these, growth factor signals will stimulate this cell to proliferate, divide, and everything else. And in the face of infection, inflammation, or anything, these cells will be stimulated. And then when the infection is done, this stimulation is turned off and the cells revert. In the case of the BCR-ABL fusion protein, they don't need any external signals. The signaling is always on because of this fusion gene, and it interacts and plays roles in proliferation and in adhesion and in transformation. And therefore you see the phenotype of CML patients where they have a high white blood count. They have immature circulating progenitor cells from the myeloid lineage. And this is what leads to all the pathogenesis. CML is actually a very, very simple cancer. And it was kind of fortuitous that we chose this cancer to first work on molecular medicine because it's very simple. It's a one hit mutation in virtually all patients. But what happens with imatinib, the new drug that was found by Dr. Drucker and Novartis colleagues, is here is the depiction. Here's the BCR-ABL fusion gene. Here's the ATP active binding pocket. And imatinib comes in and competes with the signaling mechanisms and basically turns the light switch off, stops it from proliferating. And that's how it works. And it turns basically like turning the light switch off on a wall, and the lights go out and the cell stops growing. So what have we learned in the 21 years since imatinib has been first FDA approved? Well, we've learned many things. First, we've learned that cancer cells are very smart. They're just like bacteria who develop resistance to antibiotics. Similarly, CML cells learned how to develop mutations in that ABL binding pocket such that they could become resistant to imatinib. And you don't need to look at all the specifics here, but these are all the mutations that have cropped up in various patients to imatinib over the years. And so therefore the scientists need to keep ahead of it. And they develop second generation drugs, and then the leukemia cells developed mutations to the second generation drugs, and they've developed third generation drugs. And even now, just last year, a fourth generation drug, and these are all tyrosine kinase inhibitors, has gained FDA approval. And it's not important for you to remember all these names, but just to remember that it's important that we've tried to keep ahead of the resistant mutation development in CML. Also importantly, imatinib was not developed specifically for CML. Imatinib was pulled off of the shelves at Novartis by Dr. Drucker and Novartis scientists, and it was sitting there on the shelf, and it was shown by their science that it could inhibit the ABL gene, but it also hits other genes, and we use it in other cancers. But it wasn't very potent for CML. The second generation drugs, dasatinib and nilotinib, were developed specifically for CML and specifically to hit the ABL oncogene, and are much more potent and effective than imatinib. And when imatinib first came out, we talked about it being lifelong therapy. But in fact, dasatinib and nilotinib are 150 to 200 times more potent than imatinib, and they're so effective that we are now stopping therapy after patients have been in a PCR negative remission for several years. And some of these patients are not relapsing, might be cured. Jury's still out, but it certainly looks like with these more potent second and third generation tyrosine kinase inhibitors that we may in fact be curing CML. Let's move on to a different disease, acute promyelocytic leukemia. APL was previously known as the M3 subtype of AML in the old FAB classification system. And it was long known that acute promyelocytic leukemia patients had an increased risk for hemorrhage and DIC, especially after starting chemotherapy. And that's because these are promyelocytes, these big, huge cells are promyelocytes, and you see all these granules in their cytoplasm. Well, when you give chemotherapy and lyse these cells very rapidly, all these granules are released, and the granules contain procoagulant materials, and that leads patients into actually worse DIC than their initial disease state. But we also knew that if you could get these APL patients to survive through the first few weeks, their chance for cure from chemotherapy was significantly better than all the other FAB subtypes of AML. In 1977, Janet Rowley again, she was instrumental in CML. In 1977, she first reported that there was a recurring chromosomal translocation of chromosomes 15 and 17 in association with APL. And around 1990, the face of APL started changing with simultaneous advances in both clinical care and the science of APL pathophysiology. That I'll show to you here. In 1988, a group from China described the use of all trans retinoic acid, a vitamin A derivative, in the treatment of acute promyelocytic leukemia and published their findings in the journal Blood in 1988. None of us believed them. I mean, all of us were like, oh, the Chinese saying vitamin A cures acute leukemia? Come on. And no one believed them until the French reproduced their findings a couple of years later in 1990. At the same time as everyone was saying, yeah, maybe they were right, several scientific groups around the world simultaneously reported and co-published together the cloning of the 15-17 breakpoint, and showed that the retinoic acid receptor alpha, which was mapped to chromosome 17 in 1987, was rearranged and fused to a new oncogene called PML for promyelocytic leukemia. It then bounced back a few years later, while all this basic science findings were coming. The Chinese again reported a different compound and used arsenic trioxide in acute promyelocytic leukemia, and showed that it also had effects on APL just like retinoic acid did. This time we believed them a little quicker, but again, they're talking about using the old family poison to treat acute leukemia. And so it was a little hard to believe. But it was later found that this fusion gene caused developing white blood cells to have a block of differentiation at the promyelocyte stage. And that's why all these cells piled up at the promyelocyte stage. Whoops. And it increased self-renewal and it inhibited apoptosis. And if you look then at the science, so this is the fusion gene, the chromosomal 15-17 translocation that results in this PML RAR alpha fusion gene, and it's depicted as binding to double-stranded DNA. And in the normal state of the normal leukemia, the leukemia cells have massive self-renewal, and they have inhibited apoptosis, and they have a block of differentiation at the promyelocyte stage. If you treat patients with retinoic acid, this activates coactivators, and it decreases and blocks self-renewal. It has some effects on apoptosis, but its main effect is to remove the block of differentiation, and these promyelocytes then mature into normal mature neutrophils and die a normal regular neutrophil death. At the same time, if you use arsenic, arsenic also blocks self-renewal, but it has mild effects on differentiation, but major effects on apoptosis. If you combine the treatments, and this was shown just 9 years ago now, if you combine the treatments and use ATRA and arsenic, you can now see that, and we generally consider that if a patient is in remission from their acute leukemia 2 to 3 years after therapy, they're basically cured. It's not like they have late relapses like breast cancer. So that the cure rate for ATRA and arsenic with no chemotherapy is now in the 90-95% range for APL. And so present day, over the last 8 to 9 years since this publication came out in New England Journal, we do not use chemotherapy at all anymore, and we cure 90+% of patients with APL. And it was because we understood the fusion gene and the science resulting from this chromosomal translocation. So what about solid tumors? Thus far, we can most readily target gene fusion mutations, point mutations, or amplifications as they occur in oncogenes. And anything occurring in oncogene, we can kind of target it. There are some common mutations that we have a harder time with. RAS is one of the most mutated oncogenes in all of human cancer. You see RAS mutations in 90% of pancreatic cancer, 50% of colon cancer, 30% of lung cancer, and it has proved tougher to target than other gene mutations, but we're just now getting there with the first phase of agents that target RAS. There are also some very deadly cancers that are proving elusive, such as pancreatic cancer and glioblastoma. And in general, we do still not have a good approach for targeting tumor suppressor genes. So the main two gene families for causing cancer are oncogenes or tumor suppressor genes. And whereas the typical pathogenetic mechanism of oncogenes is point mutations or amplifications, the typical pathogenetic mechanism for tumor suppressor genes is that you lose that tumor suppressor gene as opposed to an activation mechanism. And thus far, we haven't figured out a very good way of targeting tumor suppressor gene loss. But we have done a very good job at targeting some of these. And so this gives you targetable lesions in non-small cell lung cancer. And so that just 10 years ago, the only thing we had to offer lung cancer patients was chemotherapy or radiation therapy. Now you can see that there's a multitude of different fusion genes, amplification genes, splicing genes, truncations, etc., in many, many, many different genes in lung cancer. And we now have targeted agents for virtually all of these. And it's not the same targeted agent. It's, you know, an agent for ALK, an agent for RET, an agent for MET. And most of these are in very small percentages. And so it's kind of like winning the lottery. The lottery is multi-present today because the jackpot's over $1 billion. But for cancer patients, lung cancer patients, they are hoping that they have one of these very rare mutations such that they can go on targeted agents. So let me give you a patient case. This is actually a patient of mine, 66-year-old white female, presented in January of 2020, just as the pandemic was starting, presented with dizziness. Initially, it was thought that she had a subarachnoid hemorrhage, but further workup showed she had probable leptomeningeal metastases. And subsequent CT scans showed that she had a 4 by 6 centimeter right upper lobe lung mass that was adenocarcinoma proven by a biopsy, and she had multiple metastases all throughout her lungs, throughout her liver, throughout her abdominal nose, and possibly an ovarian met. She made the decision to roll the dice and take her chances. She knew that her chances of responding to chemotherapy with this multitude of metastases was very, very low, as well as any kind of cranial radiation. She said, no, I'll wait the few weeks and roll the dice and put my hopes on genetic testing. Well, she won the lottery. The genetic testing showed that she had an exon 19 mutation in EGFR, which is epidermal growth factor receptor. She was started on oral therapy with osimertinib, which targets EGFR, and it can cross the blood-brain barrier. And she entered complete remission and has remained thus far the same on this same osimertinib for over 2.5 years, still in CR, never seen chemotherapy or radiation therapy. We can go back now and show that not everybody has this, and she had this EGFR mutation, and a lot of patients have RAS mutations. Those are more common, but in general, these are very rare, but if you get it, you're in good shape. There are other cancers where we have targetable lesions. And I won't go through this list, but you can see that it spans the spectrum: melanoma, thyroid, hairy cell leukemia, giant cell tumors, lymphomas, cholangiocarcinomas, which used to be very, very difficult to treat. We now have targeted mutations for those. GI stromal tumors, mastocytosis, hypereosinophilic syndrome, you name it. So we have many targetable lesions in solid tumors these days. We also have targetable lesions in breast cancer. Some of these are actually tumor suppressors, but we do have targetable lesions in addition to our hormonal therapy for breast cancer. So if you have a particular genetic mutation for which there is a targetable therapy, there's a very high likelihood that you'll respond to that targeted therapy and you will not need chemotherapy. Conversely, if you do not have that particular genetic mutation, it really doesn't do you any good to try this very expensive therapy because chances are nearly zero that you'll respond. And just a hint, as clinicians might look at some of these names, look at the drug's generic name. If it ends in ib, such as nib, sib, jib, it's a targeted agent, usually a signal transduction inhibitor, and usually comes in a pill form. If the drug's generic name ends in mab, then it's a monoclonal antibody. Monoclonal antibodies are much bigger molecules and usually have to be given by an IV shot or an IV infusion. So speaking of monoclonals, let's move on then to immunotherapy. And immunotherapy is similar to genetics targeted therapy, but a different approach. And this highlights the work of Jim Allison, who 4 years ago was the co-winner of the Nobel Prize along with Dr. Honjo for their work on T cells. And the concept here is that under normal circumstances, there are brakes on the body's on a person's immune system to keep it under control. So think of a car going down a steep hill and the brakes in the car are keeping the car under control and keeping things in check. Checkpoint inhibitors remove those brakes in the immune system, allowing the immune system to kind of basically go wild and let the car go flying down the hill. And Dr. Allison's work and Dr. Honjo's work isolated this to this interaction between T cells and tumor cells. And it's the interaction between PD-1 and PD-L1. And this is the brakes in the car. And this is what keeps T cells from interacting with tumor cells and taking them out. If you give a person a checkpoint inhibitor, an anti-PD-L1 monoclonal antibody, you remove those brakes and the T cell is therefore then allowed to go wild on the tumor cell, but also lets the rest of the immune system go wild, which I'll get to in a minute. So another case, this is another patient of mine, 52-year-old African-American female presented in about a year ago with pericardial tamponade. She underwent a pericardial window procedure emergently, and it was after that procedure that the pericardial biopsies that were taken came back as positive for metastatic adenocarcinoma compatible with lung cancer. Chest CT scans showed that she had a primary 3 by 3 centimeter right upper lobe lung lesion, and further metastatic workup showed that she had brain lesions, and biopsies showed that they were metastatic lung adenocarcinoma. She underwent resection of some of the brain lesions and cranial irradiation. She underwent genetic testing, just as we did the genetic testing for the first patient that showed that the EGFR receptor mutation, and her genetic testing showed that her tumor expressed 100% PD-L1. Again, a lottery winner, a jackpot. And she received 2 cycles of combined chemotherapy and immunotherapy, followed by immunotherapy with pembrolizumab alone every 3 weeks. CT scans performed 6 months after starting the therapy showed a complete remission, and she remains in complete remission on immunotherapy, a shot every 3 weeks. Another patient that I'll point out to you is former President Jimmy Carter. Jimmy Carter was announced in August 2015 that he had melanoma with liver and brain metastases, and immediately started singing his swan song and said he had weeks to live. But he was then placed on pembrolizumab, same drug, and today is in complete remission, and last month celebrated his 98th birthday. He started this therapy 7 years ago when he was in his 90s. So and this isn't for you to write down and focus on, but this is the number of organs and cancers that pembrolizumab has gained FDA approval on. Started with melanoma, non-small cell lung cancer, but just look at the multitude of different solid tumor cancers that pembrolizumab is now FDA approved for. Their package insert is well over 100 pages. We kid the drug reps that they can use it as a door stopper because it's going to change by next week anyway. So why keep publishing it, because it goes out of date so quickly. The problem is that when you give checkpoint inhibitors, you are allowing the immune system to go wild. And so that these drugs, while they're very effective, they do run the risk of side effects. I'm going to go through the adrenal side effects in a little bit more and just on the next slide. But patients can have encephalitis, meningitis, pneumonitis, hepatitis, myocarditis, colitis, you name it. They can have any itis you can think of. And it's because the immune system brakes have been removed, and it's allowing the immune system to go wild and have all kinds of autoimmune and other effects. Primary care physicians need to be on the lookout for this and need to be on lookout for all of the endocrine side effects, from hypophysitis to thyroid dysfunction to diabetes to adrenal insufficiency, because while the oncologist is going to continue to treat these patients, that patient may walk into your office and have some of these side effects or have some of these side effects, or they may walk into the emergency department with some of these side effects. And if you don't pick up on that they're on one of these checkpoint inhibitor drugs, you may be doing them a big disservice. So I encourage you to study up on these. These are all related to these drugs that are all checkpoint inhibitor monoclonal antibody drugs that can have all of these immune-related side effects. So take-home message, and this is my last slide. Because the majority of these targeted agents and or checkpoint inhibitor immunotherapy drugs are very, very effective with very few toxicities, apart from the immune-related stuff. And again, those are small percentages, but you have to be aware of them. Virtually all patients should get their tumor biopsy sent for genetic testing, and that's PD-L1 expression, and that's regardless of their patient's age. Remember, Jimmy Carter started this when he was in his 90s, regardless of comorbidities, regardless of stage of cancer. I think the only exception here would be is if in judging the patient, you think they have less than 2 months to live, then maybe not. But in virtually every other situation, the patient needs to get their tumor biopsy genetically tested. And there is absolutely no way to predict genetic mutations based on histology, stage of disease, disease aggressiveness, or organ of origin. The problem is that genetic testing generally takes a few weeks. And so you have to decide, are you going to give them interim therapy, hoping that they're a lottery winner and they have a genetic mutation, or do you bide their time and still hope that they do? And if they don't, then they have to still face our old chemotherapy mechanism. But I think over the last 10 years, we have changed the face of cancer therapy because of these new advances in precision medicine for oncology. And with that, I'll thank you, and the panel will take any questions you might have.
Thank you. That's absolutely great. And Dr. Shihabi, any comments that you want to add, or just based on what Dr. Emanuel has said?
Yeah, thank you, Dr. Emanuel. It was a very elegant presentation indeed. I started working about 20 years ago, and I actually remember attending a plenary session at the American Society of Clinical Oncology, where breakthrough study, so to speak, comparing 4 different types of chemotherapy for lung cancer. Well, they're all identical, and the median survival at that time was about 9 to 12 months. It's amazing how now these days, when we start treatment, we're telling patients that expect possibly a median survival of 3 to 4 years. And in my personal experience, I have several patients who actually stopped immunotherapy after achieving a remission and have been in remission without any treatment for a couple of years. So, it's really an exciting time to be an oncologist. And I think, this knowledge should be disseminated across all disciplines.
I've been around for a while as well as a primary care doctor, and just to see the evolution of these acute onset malignancies that are all of a sudden everywhere and patient dies 3 months later, to what we have today, which is sort of chronic disease management. It's incredible. The other thing that I think has really changed has been it was always, well, we'll do conventional treatment first, radiation, chemo. And if that doesn't work, maybe we'll do some sequencing and look for it. But it's really changed. And Peter, I think you've really, pointed that out, that many times people don't start with standard treatment. I guess we have to change the definition of what standard treatment is.
Well, and I think the other part of this is, and this may take some years to evolve because we're creatures of habit, but, rather than a lung cancer clinic or a pancreatic cancer clinic or something like that, I think we're getting to the day and age where patients are going to be more identified and treated and everything else based on their genetic mutation, regardless of what organ it started in.
Yeah, absolutely. Jill, from where you sat 20 years ago, what do you think of what's happened today?
Yeah, I really like the starting off with the CML example. I was trained in cytogenetics, so the karyotype with the chromosomes, I spent years at the microscope looking at them, looking for 922, looking for 15, 17 translocations. I wish the chromosomes looked as beautiful as the ones Dr. Emanuel had in his
Right.
karyotype would make that job a lot easier. But, the fact that we've been doing this, people think precision medicine and precision oncology is the future. It's not. It's actually what we've been doing. We've just now evolved, and our technology has evolved and our knowledge has evolved. That this really isn't anything new. It's just now we know so much more. And while we've gotten better from the technology side, we need to get even better. 2 weeks for next gen sequencing. Okay, that's good. It needs to get better when patients need to start treatment. So, while we can sequence anything now, produce great sequence data, relatively speaking, compared to old school techniques like PCR and things like that, NGS just isn't quick enough. So we need to continue pushing from that way as well.
Great. It does seem that every new drug that is advertised from dermatitis to hay fever has AB at the end, something AB. And then the warning, you could get serious infections, lymphoma, and so forth, comes over the television. I mean, it's just amazing the proliferation of all of these monoclonal antibody drugs that are treating folks in all these different conditions.
Unfortunately, with all the escalation in knowledge, also comes escalation in treatment costs and costs to society.
Yes.
All these tests cost tremendous amount of money, plus the targeted therapy, and often now we combine 2 or 3 together. So we're going to have to deal with that as we are learning more about how to treat these cancers.
Yeah, and certainly during COVID, we all in the primary care world, got very introduced to monoclonal antibodies for treatment for patients with COVID, or pre-treatment. Well, I guess treatment for patients with COVID primarily.
The other thing that we're waiting for solid tumor therapy to catch up on, we learned from CML, is we're just at that stage now of using targeted therapies in solid tumors where we'll likely start seeing some disease resistance emerge. And then just like CML, the scientists are going to have to be on top of things to develop the second generation, the third generation. And that's going to be the next kind of cusp of things, because some patients will be cured, some patients will need to stay on therapy. Some of these target agents will be more potent than others. That's the whole next challenge.
Well, I on behalf of our entire team, want to thank you. This has been an absolute great conversation. And I think for those of us who are non-oncologists, you've really kind of helped us understand and kind of see where we are. And I think we all see it in practice, but this is sort of the whys. So we really appreciate that.